So, Dr. Pritesh, are we here? Can we start?
Yes, I will start.
Okay, so today we'll just have a small discussion on this topic of orbital fracture, and we have our presenter, Dr. Shubham, and Dr. Ritesh Shetty will be moderating the session. Okay, so today we'll just have a small discussion. Okay, so I'll just introduce, give a brief introduction for Dr. Shetty. So Dr. Pritesh Shetty, he's the head of Department of Oculoplastics and Oncology and Aesthetics at Bachu Ali in Mumbai. And he's one of the youngest surgeons around in Mumbai. And he also trains fellows in his department. So he has taken time out for this discussion. And Dr. Shubham, can you introduce yourself?
Yes, sure, sir. So, hi everyone. Good evening. This is Dr. Shubham. I am a first-year resident in ophthalmology at Narayana Nethralaya, Bangalore. I finished my MBBS from KM Hospital, and I am in, I think, my 8th month of residency. Yeah.
Okay, so we have two young people. Okay. So let's start. Okay, and Dr. Shetty, you can take over.
Yeah. So Shubham, you're starting with a case presentation, right?
Yes,
having
sir,
a case presentation?
Yes.
Okay. So we'll start with the case presentation, and we'll take the questions at the end of your presentation.
Okay, yes, sure, sir. So, good evening, everyone. This is a case presentation, a discussion on orbital blowout fracture. So a 26-year-old male with a history of road traffic accident 3 months back, he came to the OPD with chief complaints of disfigurement of face and an occasional diplopia in the left eye with movement. So his past history states that he sought treatment in a nearby corporate hospital and a nearby eye hospital as well. He was told that there was no intervention needed from ophthalmology point of view, and he says that his left eye was swollen after the accident. On general examination, the patient was absolutely fine. There were no systemic complaints. And on ocular examination, his head posture was erect. His left eye looked sunken. His visual axis was orthotropic. And his visual acuity, as we can see, was 6.6 and 6 without correction. And his pressures as well were normal. On further ocular examination, we did not find any abnormalities in any of the anterior segment or posterior segment findings. I'll be showing a video of the extraocular movements in the next slide. Yeah, the video is playing, right?
Yeah, it's playing.
So this is just an inspection of the eye showing the left eye being sunken. And as we'll see the movements, abduction and adduction seems fine, whereas left eye seems to be, sorry. Yeah, so the left eye seems to be, movement seems to be restricted in the up gaze. Yeah. So before going on to the investigations, I'd like to just ask a sir or maybe someone else to contribute as to how we should approach this case when we see a patient like this in the OPD.
Okay. What did you ask in the history? What else did you ask in the history?
So, sir, I'd like to put clear this at the outset that the case was not actually mine. This case
I know. I have seen the patient,
yes.
so I know.
Yes.
So suppose a patient of a trauma comes to you. What all other questions you ask to the patient?
Yes. So since this is assuming a similar patient who has a history of old trauma, or in an acute case of trauma,
or fresh trauma.
Yeah. So in an acute case of trauma, first of all, I would like to know what the exact time of trauma, the site of trauma, how the trauma happened. If whether it was a blunt force or a penetrating trauma, whether whether the patient has blurring of vision after the trauma, whether there are any external injuries, whether there is any tenderness or pain around the orbit. Then yeah, I think
that much only you'll ask. Anything else?
Again, the whether there is any double vision.
Okay. You're talking about fractures. Suppose you're talking about fractures. So what particular history you would like to take? Yeah, I think so. Dr. Sangeeta has messaged.
I will take it.
Yeah, so you should ask about any ENT bleed, loss of consciousness, convulsion. Those things are the most important. So if ENT bleed is there, that gives an indirect clue that there is some fracture. Because if the fracture is there, then only the blood will go into the sinus and you'll have that ENT bleed.
Oh, yes, sir.
Okay. So history-wise, this much things has to be taken into account whenever there's a history of a trauma. The main thing you have to ask about ENT bleed and loss of consciousness. Okay, loss of consciousness, convulsion. Again, you have to rule out any intracranial pathology that is there.
Yes, yes.
Yeah. So someone has answered crepitus and all that comes into the examination part. Okay. Okay.
Okay.
So your question is, how should we proceed? Hello, someone is asking something.
Dr. Alisha, any questions? I think Shubham, you can go ahead. How would you like to proceed, and what are your
yes,
suggestions?
Yes, sir. So in this case, since we've already summarized the findings about the left eye being sunken and there being a restriction in the upgaze as well as occasional diplopia in the left eye.
1 second, Shubham, if
yes.
you're telling about sunken, then how you make a objectively you can measure, how you'll measure the sunkenness?
Yes, ma'am. Yes, sir.
Something else?
Yeah, we would measure with a Hertel's exophthalmometer.
Hertels will help. Hertels will help in this question. In this situation, Hertels will help.
Yes, it should give me an objective reading.
Yeah, but which will be a better one? Anyone else? Second year, third years?
Dr. Akhtar, you want to say something?
Second year, third year. When would Hertel help, and when in this condition, which other exophthalmometry will you like to do?
Anyone from the audience can unmute and answer? So basically,
Hertel will give you a rough idea, but Hertel is generally used for axial proptosis and axial lesions. So better in this condition, it will be to use a Lutz exophthalmometry. Because what happens in Hertels also, it is placed onto the lateral orbital rim. So suppose a patient is there who has a floor fracture, lateral orbital rim fracture. So that kind measuring the exophthalmometry with a Hertel will be difficult because it will be painful to the patient. So either use a Lutz or either use a double scale technique. The double scale technique will also give you a vertical diplopia, a vertical dystopia, horizontal dystopia. Those all things can also be measured with the double scale.
Yes.
Okay, Hertels generally preferably avoid it in a trauma patient because it will be painful placing the Hertel onto the lateral orbital rim.
Yes.
Okay. Yeah.
Yeah.
Sure.
So,
What investigations you'll do for this patient?
yeah. So we've sir had ordered a CT scan of the face. So I'll just be
what
showing
you
the
write?
video.
What you write in the CT scan? In the requisition?
Yeah, with either 2 mm or 1.5 mm cuts of the orbit.
Okay.
And there's one more thing where where we have to specify what has to be the
You'll advise a
the
plain CT or contrast CT?
no, plain CT would be fine here.
So CT of what area would you? Do you want a CT brain? Do you want a CT chest?
No, I said CT face with 2 mm cuts of the orbit along with CT brain.
See, if you say CT face and CT orbit, the brain is automatically
Yes.
comes in that. So you
Yes.
don't have to mention CT brain in that. But if you say CT brain, the orbital cuts are not. So better to order for a CT orbit, plain, 2 mm cut, and all the views, sagittal, axial, and coronal view.
Yes.
Okay.
Yes, sir.
Okay. Next video. You're going to play some video, right? Of the CT
Yes.
scan?
Yes.
Okay. Stop.
Yeah. 1 second.
Okay. So describe this CT.
Yes, sir. So this is a coronal section of the CT face with the coronal section with the left eye showing. Just let me open up the pointer 1 second. With the left orbital floor showing extrusion of either orbital fat along with muscle.
Okay. So you can, with the pointer, you can show the muscle, inferior rectus muscle.
Just 1 second. I'll play the video, sir. 1 second.
Okay, stop it.
Yeah,
Pause it.
1 second. It's not.
It's paused.
Yeah, it's paused.
Yeah, just pause it and show.
Yeah.
Yeah. Okay, just pause it and show me
here.
the inferior rectus muscle in this.
Yes, 1 second. Yeah. So basically in this section, we're able to see the inferior rectus. As soon as I open my pointer, I'm not able to control the video. That's what.
Okay.
Yeah.
Okay. Just show me the inferior rectus muscle. Where the inferior rectus muscle?
Yeah.
Can I not able to pause it?
Yeah, no, I've paused it.
Okay.
The video is paused, right?
Yeah.
So yeah.
So the
Yes, sir.
the
So
pointer is, what is that? You're placing the pointer. What is that?
Yes, this looking at the density of the structures, this looks like the inferior rectus muscle to me.
No, that is the fat.
1 second.
Okay, pause it.
Yeah.
So that structure which is more inferior, that is the fat. Okay, the pointer is there. It is the fat. Go a little bit medially from the fat. Okay, that area, that is the inferior rectus muscle.
Okay. Yes.
Yeah, so you can make out the density. So you compare the intensity of all the muscles, recti muscles.
Yes, sir.
So with respect to that, that is the inferior rectus muscle, and just medial to it, that is the bony fragment. which is come
Yes.
down.
Yes, sir.
Okay. So this is blowout fracture. This is a blowout fracture. The fracture fragment has gone out.
Yes, sir.
So basically, whenever you see a CT scan, you should be able to identify the fracture fragment and where the muscle is. If the muscle is above the fracture fragment, there is no entrapment, you can observe. But when it is the fracture fragment has gone down and the muscle also has herniated down, that patient requires intervention, surgical intervention.
Yes.
Okay, so these are the things to be kept in mind when you are ordering a CT and observing it. Also, you play the sagittal films also to see how posterior the fracture is.
Okay. Yes.
You have the sagittal films with you?
No, sir. No, sir.
Only the coronal. Okay.
Yes.
Okay, fine.
Yeah.
What is the
This is
sign that you
just-
see in CT scan? What is the sign that is called on X-ray or a CT scan? The classical
Teardrop
sign for a
sign.
Teardrop.
yeah, correct.
Yeah.
Teardrop sign.
Yeah.
So that is something is hanging just beneath the
Yes.
fracture fragment. So it is like a teardrop sign. Correct.
Yes.
Okay.
So this is another of the coronal sections as well, but I believe the density of the
So always compare the density
Yeah.
with the other recti
Yes.
muscles. Then you will be
Yes.
able to identify the inferior recti
yes,
muscle.
yes. Okay. So just to summarize the findings, we found enophthalmos on left eye, restricted eye upgaze in the left eye, as well as a CT scan showing herniation of orbital fat inferior rectus through the left orbital floor. So as sir has already discussed about in this case, sir, since there is entrapment of the inferior rectus and herniation of content, so you believe we should go for an orbital floor repair, right?
Yeah. So what are the signs in this patient to operate? Positive findings in this patient?
So inferior rectus entrapment, herniation of
Okay.
orbital floor fracture with inferior rectus entrapment, basically. Yeah.
Other findings? Other positive findings that you already mentioned, but
Yeah. So enophthalmos.
yeah.
Restricted eye movement, that's basically because of the inferior rectus entrapment and herniation of orbital fat and through the left orbital floor.
One more main thing that you forgot.
Fat and inferior rectus muscle.
What happens when the patient looks up?
Diplopia, yeah. The occasional diplopia.
Yeah.
Yes.
So those are the actually main points. Enophthalmos and diplopia in upgaze.
Yes.
Okay, those are the main points why we want to operate this patient. Okay. What are the theories for orbital floor fracture?
So,
You're done with the presentation? You're done
yes,
with
I'm
the
done with
presentation?
I'm done with the presentation.
Okay. Now, what are the theories for orbital orbital fractures?
Anyone else can take the question?
The questions are for everyone, so anyone can answer. It's not only for the presenter.
Hydraulic theory.
Okay. What happens in hydraulic theory?
Anyone else? Shubham?
No, Sam, I have not read.
Okay.
Yes.
Hydraulic theory and buckling theory. Okay, hydraulic theory, then when there is an external injury, it causes an increase in the intraorbital pressure, which causes the thin orbital floor and the medial wall to give way. Whereas in the buckling theory, the force is directed from the orbital rim into the weakest walls of the orbit, like the floor and the medial wall. Okay. These two theories are the important theories for orbital fractures, hydraulic and buckling.
Okay, yes.
What are the signs and symptoms of orbital fracture patient?
Diplopia,
Okay.
restricted extraocular movements,
Okay.
You're talking about signs or symptoms? Dr. Sukanya?
Crepitus.
So you're talking the signs or the symptoms?
Signs, sir.
Okay, so
Sign,
you can
okay.
just enlist them again for Dr. Shetty.
Extraocular muscle movement restriction, sir, and crepitus on palpation, sir.
Okay. And any other sign? Okay, I think Kushbu has answered a message.
The symptoms will be ecchymosis and eyelid edema with or without pain, and the signs will be infraorbital nerve anesthesia, that is cheek anesthesia, and diplopia.
Okay. Okay. Why there is infraorbital nerve anesthesia? What happens there?
Because from there, that infraorbital canal, through infraorbital canal, infraorbital nerve passes.
Okay. Where is this actually? In which bone?
So, sir, 1 minute. Sir, in infraorbital canal.
It's in maxilla, sir, the intraorbital canal.
And canal in maxilla. Yes, in
Is in the
maxilla.
maxillary bone.
Yes,
So
yes.
half of the floor is formed by the maxilla, and the rest
Maxilla.
1/3 is formed by the zygomatic bone. So fractures happen generally in the maxillary bone.
Maxilla, yes, sir.
Yeah. Okay. How do you differentiate a blowout fracture in an adult and a pediatric? What differences you see in a pediatric blowout fracture and an adult blowout fracture? With regards to signs and symptoms. Anyone? Have you heard about white-eyed blowout fracture?
A tremor fracture mainly because their bones and cartilages are soft.
So what happens?
The muscle which has been receded into the cavity can go backward. So it's like a trap door.
Okay, trap door. Okay. What symptoms they'll have?
Sir, they normally experience
oculocardiac reflex. Oculocardiac reflex.
Yeah. So what happens? What they say? What is the main symptom?
Ocular movement. Oculocardiac reflex.
Cardiac reflex, what will happen?
So nausea, vomiting, and syncope.
High decreased heart rate.
They'll have vomiting. The main complaint of them will be vomiting.
Vomiting, yes, and headache.
Yeah. And there will not be any other external signs of injury. So
Injury. Yes.
in pediatric blood fractures, we don't get to see a lot of ecchymosis, lot of lid edema. It is just a trapdoor fracture. Trapdoor means the fragment is not broken. The fragment doesn't break and go into the maxillary sinus. The fragment still stays there and the muscle gets entrapped there. So the chances of ischemia of the muscle is very high in a pediatric blood fracture.
Okay.
So hence, treating a pediatric blood fracture is an emergency as compared to adult blood fracture. Adult blood fracture, the fragment goes inside the maxillary sinus. The muscle is free. The muscle is only herniated. Whereas in a pediatric blood fracture, the muscle is herniated plus it is trapped between the bony fragments. Okay. Suppose an adult comes with a blood fracture. What is the initial management for such patient?
Ice packs, decongestant. Initial will be conservative management depending upon the symptoms and sign. So there we can advise them for using ice packs, and that to keep because it can affect the nasal sinuses. So we can ask for nasal nasal decongestants, and not to blow out their
not to blow the nose.
Yes.
And you have to start the patient initially on antibiotics because the fracture, because if the fracture is there and there is direct communication between the orbit and the sinuses, so you start the patient on antibiotics, ice packs for the ecchymosis edema to come down, nasal decongestants. Patient should be instructed not to blow the nose, not to do any heavy weight lifting. Systemic steroids can be started 48 hours after the initiation of antibiotic, just to bring down the edema. Because if the edema is there, then operating the patient becomes difficult. So we want the edema, everything to settle down. So maybe you can little bit delay the CT scan, not on the first presentation. You can just delay it by 48 hours. Once the edema comes down, then you can get a CT scan. When do you decide to operate in a blood fracture?
Only if there is inferior rectus entrapment, where the contents are herniating and there is.
And there is, along with that entrapment, there is
diplopia.
Okay.
For the patient.
Significant enophthalmos.
Okay. How much enophthalmos? How do you define significant enophthalmos in a blood fracture?
So maybe cosmetically bad looking enophthalmos, or maybe more than 2 millimeter respective to the other eye.
The general rule is enophthalmos 2 millimeter or more than 2 millimeter, and diplopia persisting more than 2 weeks. Okay. So that time you have to take a call. Whereas in pediatric, it becomes an emergency. The golden period is 72 hours. You have to operate within 72 hours to prevent the ischemia of the muscle.
Okay.
Okay. What all preoperative investigations do you do on OPD basis for blood fractures? Preoperative assessment investigation that you can do.
So routine hemogram, HB, CBC, bleeding time, clotting time.
Not about the blood investigation, ophthalmic investigation that you do.
Is there any rule for post-Daxon test in these cases?
Yeah, you can do post-duction test. Once the edema, everything settles down, you can do a post-duction. Why we are doing a post-duction test?
To delineate the muscle clearly.
To
Which muscle is entrapped?
which muscle is entrapped? Okay, how you do it?
I cannot fully memorize the procedure.
The post-duction test is done generally intra-op. You can do it pre-op also if there is a dilemma, but whether it is a traumatic, whether there is a direct injury to the muscle which has caused paralysis to the muscle, or whether there's an entrapment. Just to differentiate between them, you can do a post-duction test. But if the signs and symptoms and the CT findings are proper, you don't need to do a post-duction test before the surgery. During the surgery, obviously you do a post-duction test before doing the surgery, before starting the surgery, and also once the fracture fragment is reduced, you get the eyeball up, then also you do a post-duction test on table. Pre-op only if you want to if you have a dilemma between a between an entrapment or a neurological cause, direct trauma to the muscle, then only you can do a post-duction test.
We'll do fundus examination to look for any commotion retina.
Okay.
And B scan or to look
any
for
other test to check the extraocular movements?
Hess charting, diplopia.
Hess charting.
Yeah, Hess charting has to be done. So that gives us a clue of the post-operative improvement in the patient. Okay, so Hess charting has to be done. Applanation tonometry.
So we should avoid in acute cases, right?
Yeah, acute cases you have to avoid.
Hmm.
Suppose it is a cold case like this, the one that you presented. That time, what will be a finding in applanation tonometry in the patient patient of blowout fracture? What type of applanation tonometry you would like to do?
No contacts.
I'm talking about applanation. Applanation is contact only, no, every time. And for this case, the case that you presented,
Goldman applanation.
For the case that you presented, what will be the applanation tonometry findings? Whether it will change with case, since there is a entrapment.
Yes, it should change, sir.
Okay. How it will change?
But I'm not sure whether it should increase or decrease actually.
Okay. But in which cases you will check?
Since Goldman's, it won't be possible to check in all cases.
Okay.
But I'd like to do a tonopen in different cases.
I think checking the pressure in up gaze will help us in delineating if there is inferior rectus entrapment, because if there is inferior rectus entrapment, then in up gaze the pressure will be, I guess, increased.
Correct. So there is something called differential tonometry, something wherein we measure the applanation tonometry in the primary gaze and up gaze if you're suspecting a inferior rectus entrapment. So in up gaze, the IOP should increase, since there is a restrictive pathology where it is entrapping the inferior rectus. The movement of the eyeball will be restricted in up gaze, so that will increase the pressure. This test we can also do in which other conditions? The differential tonometry.
Thyroid eye disease.
Proptosis, thyroid eye.
Not every proptosis. Thyroid eye disease with inferior rectus involvement.
Yes.
Yeah. Okay. how we go out with the surgery? What all techniques we can do for the surgery? Orbitotomy, but how will be the incision? Which
This is a
approach?
transconjunctival route.
Transcutaneous.
Transconjunctival route.
Okay. Other routes are transconjunctival and
Transcutaneous.
transcutaneous. Okay. If it is a medial wall fracture only, then how we can approach it?
Canaliculi. Through canaliculi.
Transcaruncular.
Transcaruncular.
Sorry,
Correct. Okay. Okay. So, what all implants can be used for a blowout fracture? What all implants can be used?
Implants.
You'll have to place some implant, no, to prevent the herniation.
Yes. Mhm.
Synthetic implants, sir.
Okay, like
Mesh.
So titanium can be used. Titanium can be used,
Okay.
or
Okay.
if there is peak implants are also in trend right now. If there's a big fracture, there's a big disability.
Okay. What else? Or other materials that can be used? Any autogenous? Autogenous implants?
Bone graft.
Okay. Bone grafting. Which all bones can be taken?
From iliac crest, sir.
Iliac. Iliac crest and
Fibula, sir.
fibula is the least. Iliac crest and other thing? From the chest?
Ribs.
From the ribs can also.
Yeah, rib can be taken out. Any cartilage?
Yes, nasal septum, from the nasal septum, or auricle.
Which, pre or post?
I'm not sure about that.
Post auricular cartilage.
Post-auricular.
Post auricular cartilage can be used. Okay, but only problem with autogenous implants are that they get resorbed. So at the end of maybe 3 months, 6 months, that the implant is completely resorbed. You won't be able to see the implant, and there can be again chances of herniation of the orbital contents. Okay, and those are the cartilages are not that strong enough to hold on to the orbital contents. Hence, synthetic implants are used. The most commonly used ones are titanium. So titanium you get as a mesh where you have to shape it according to the fracture site, or you get preformed orbital floor middle wall implants also, which are 3D printed. So you can use them also. What are the steps, roughly the steps in orbital floor fracture repair?
So the incision is made and periosteum is lifted, sir.
Where is the incision taken? In transconjunctival, where is the incision taken?
Transconjunctival. In floor fracture, we will go through with the inferior fornix.
Okay, inferior fornix. What structure we have on the conjunctival area? Below what structure do you take the incision? What is the skeletal of the eyelid?
Below the tarsus, like, do we take it below the tarsus?
Yes, we take it
Tarsal
below the
plate,
tarsus.
yes. Tarsal
Yeah.
plate.
So that is more specific. You take it below the tarsus. Then what is the next step?
Then we have
Then we elevate the
4R.
periosteum.
If you open up the
Elevating the
tarsus, you don't see. Yeah, you don't see the periosteum directly.
Okay.
Once you take out the tarsus, you have to do a blunt dissection. You have to bypass the orbital septum. You don't want to open up the orbital septum, otherwise the fat will pop up. So you have to go bypass the orbital septum, then hit the bone, then take an incision over the periosteum. Okay. After that, you elevate the periosteum, lift up the entrapped structures, get them into the orbit, inspect the fracture site. Suppose if you have a med-pore implant or a titanium mesh, then you will have to make a template. How much amount of implant has to be put inside? You have to make a template, and the same amount has to be cut onto the mesh or onto the med-pore, and then you place it inside. Either you can glue it also, or you can just leave it there. Then you do the post-duction test again. Post-duction test again to check whether the fracture fragments have been reduced, the movements are normal or no. After that, you close up the conjunctiva and leave it. Okay, that much is the transconjunctival route. So before starting the procedure, also you do a post-duction test to check for the restrictive pathology. Then you go with the incision, reduce the fracture fragments, put in the implant, close off only the conjunctiva. You don't have to close the periosteum. You don't have to close the muscle. Nothing. Just close up the conjunctiva with 3 sutures. That is enough. What are the complications that can occur during the surgery?
Overcorrection or undercorrection of enophthalmos.
Overcorrection. How will overcorrection happen?
Hemorrhage can occur, sir. Hemorrhage can occur.
Okay.
There can be.
Infection.
Okay.
Visual loss due to excessive traumatic intra-op manipulation of the optic nerves.
Yeah, so that is the one of the most important criteria that has to be explained to the patient, that vision loss can happen with these corrections. Even if you're not touching the globe, you're not doing much handling, vision loss can happen. Other complications?
Injury to the levator complex can cause any ptosis, sir.
Why levator?
Not an exactly transconjunctival incision, sir.
Okay. Levator is in the upper lid, right?
Yes, sir.
We are mostly talking about
Can
the
there
floor
be a
fractures now.
displacement of the implant that we have put in? That can be a complication too.
Yeah, that can be a complication.
We can
Even
injure it infraorbital nerve.
That can happen. Infraorbital nerve anesthesia, post-surgery also.
Migration of
What is, suppose you're getting a floor fracture, what is medial to it? What structure is medial to it?
Lacrimal apparatus.
Yeah. So if that gets blocked, what do we have?
Epiphora.
So secondary acquired nasolacrimal duct obstruction, SALDO, can happen. Okay. Whenever the implant is there, it blocks the nasolacrimal duct. So there you can have secondary dacryocystitis also, nasolacrimal duct obstruction also. So since the implant is synthetic, there can be chances of the implant getting extruded, implant forming a fistula, abscess, infection. Okay. What is hypoglobus? What is hypoglobus?
Downward displacement of the globe.
Okay. What are the causes?
Trauma.
So this floor fracture.
Okay. And other causes? Just imagine, no, water structures, if they are not there, and can the globe shrink down?
Hypoplasia of the zygomatic.
What is the bone below the orbit, below the globe?
Maxilla.
So if that bone is not there, then what will happen? The whole complete bone is not there.
So the eyeball will descend downward. Silent sinus syndrome.
The whole bone, what happens in CA maxilla? Surgically, what they do?
Maxillectomy, basically.
Yeah. So status post maxillectomy, there can be a huge amount of hypoglobus.
Okay.
Mhm.
Any other questions you want to ask?
So most of the time when patients come to the casualty, like the first thing they want to know is like, with the injury obviously of the orbits, they want to know like if they have any fractures or not. But as you told that the CT should be delayed to like 48 hours, but like sometimes we have to discharge the patient from the casualty due to non-availability or like of the bed. So what should we do in that cases?
Means a patient of trauma has come to you and you don't have a bed.
So for example, like we have bed, the
Yeah.
patient is occupying a bed and we want to
Okay.
discharge that patient, like telling him like, do you have a fracture or you don't have a fracture, like then
No, it's not every time that you have to delay the CT scan. I'm only telling if you have intense edema, lot of edema, ecchymosis everywhere, that time you have to delay the CT scan. If the
Okay.
edema, ecchymosis is not too much, which will not give a false reading, false perception, there is no fracture, you can go ahead with the CT scan.
Okay.
But it is always better to assess the patient maybe after 3 days of giving him antibiotics and steroids. For once the edema comes down, it will be a better assessment for you, because even then you can assess the extraocular movements also. Initially, if the patient comes to you with acute trauma, it is difficult to assess the extraocular muscles also in such kind of patients.
Yes.
So you can go ahead with the CT scan. There is no negative thing about not going about the CT scan. You can go ahead with the CT scan, but always try to correlate your CT scan with your clinical findings also. Because at the end of the day, you're not treating the CT scan, you're treating a patient.
Yes, sir.
Yeah? So you can go ahead with the CT scan. There's nothing wrong with it. But if you want to reassess, give a time of 3 days, give him antibiotics, give him steroids, give him LIMC, vitamin C supplements, and then you get a proper assessment. So every patient of trauma, you don't do a CT scan. Blindly, you don't do a CT scan for every patient.
Yes.
There has to be some clinically, some signs has to be positive for you to do a CT scan. Crepitus. If there is a subconjunctival hemorrhage, which you can't locate the posterior edge of. If there is a ENT bleed. Okay. If there is diplopia, is very difficult to assess in acute trauma. Extraocular muscle restriction also is difficult to assess in acute trauma. So give the patient conservative management 3 days, and then you call him back after the 3 days, get a CT scan done. Then when you have positive findings of restricted extraocular movements, diplopia, infraorbital nerve anesthesia. Yeah. So there is a wrong notation going around on many of the hospitals that they do a CT orbit for every patient suspected of facial trauma. You don't have to do CT orbit for every patient. Only if the positive signs are there, then only you do a CT orbit.
Okay, sir.
Any other questions? Any questions regarding orbital fractures? Anytime you would like to do a MRI in a fracture patient, any condition?
Sir, if the fracture patient has an RAPD or severe visual loss.
Okay. So that can be a combined blowout fracture plus a
Yes.
traumatic optic neuropathy. So we would like to do MRI in such cases.
Yes, sir.
Yeah. What happens if you don't operate?
Sir, actually, I was going to ask you whether the reason behind operating a patient with IR entrapment is just
Okay.
symptomatic, or if there is anything more sinister that can happen if we don't operate.
If you don't operate, what happens? Entrapment is already there. Muscles are already entrapped down. So it can lead to more and more fibrosis and more and more enophthalmos. So enophthalmos can increase also.
Okay.
So, sir, the patient that you have presented now, he has come to us after 3 months.
Yes.
And he never knew that he had a blowout fracture. But clinically, he had gross enophthalmos, upgaze restriction, infraorbital anesthesia. Even though it is very late for him to present to us, but it is always good that we operate, at least anatomically, we fix the orbit to the normal position and give the muscle a chance to recover.
Yes.
So had we operated earlier, obviously the improvement would have been better. But now what will happen, because the entrapment is too much, there is hardly any bony fragment in the inferior wall, the floor. So there will be a lot of fibrosis which will keep on happening, and that will lead to a lot of enophthalmos. The enophthalmos can increase also in such kind of patients.
Sir, in this case, we even post-operatively, we would expect a decreased restricted upgaze, or say because of the fibrosis.
Yes.
Okay.
So every patient, not only for this case, for every patient of blowout fractures that you operate, always tell them that we are just fixing it up anatomically. We are getting it to the normal position. Diplopia may or may not persist.
Okay.
Diplopia may persist. It may persist in end gazes, but it can be there. Diplopia can be there. And also in pediatric cases that you operate, tell them that the improvement won't be the next day or the next week. It will take months together. It will take 1 month, 2 months. Most of the pediatric cases, the muscle has undergone ischemic changes. So it takes a lot of time to improve. So it takes a month or 2 months to improve. Finally see some movement happening, it takes months together in pediatric cases. But it will come. So most of the pediatric cases end up with only end gaze diplopias.
Yes.
Diplopia in up gaze is still okay. Diplopia in down gaze is more worrisome. Okay. Was your reading habit? Because all pediatric cases generally they read. So reading textbooks and all, that will be the most difficult part.
Yes.
If they have diplopia in up gaze, that is still manageable. So later on, they may require some pediatric squint surgeon intervention also, either with a prism or with some squint surgery, if it doesn't resolve. Was the thing with pediatric is it is a whiteout blowout fracture. Generally, there are no external injuries, so parents also take it lightly. So they come to us after a month and a half of the injury. So always in your consent, it is always mentioned that diplopia may persist.
Yes.
Either you operate an acute case or a cold case after a month and a half. Any questions? Okay, I think so. Dr. Anuj is stuck up in traffic. Anyone has any questions? Okay, Dr. Anuj is stuck up in the traffic, so we'll just close the session as it is 1 hour over. And if anyone has any questions, they can reach out to Dr. Anuj. So he'll coordinate with me and I'll just answer the questions back to you.
All right. Thank you so much, sir.
Yeah.
Thank you, sir.
Thank you, sir.